Hello, welcome to New Wine Tastings. I'm Paul Louis Metzger, the director of the Institute for Cultural Engagement, New Wine, New Wineskins. And New Wine Tastings is giving us a taste of New Wine's approach to cultural engagement, which is building relational bridges through Jesus in contemporary culture. One of the areas we seek to do that in is between faith and science, building those bridges. And today we're finishing off a series on a personalist approach to medical ethics with Dr. Robert Potter, whose areas of specialization include internal medicine, palliative care, geriatrics, and medical ethics, and is a personalist in terms of his approach. University of Kansas Medical School and University of Chicago Divinity School. So he's a hybrid, a polymath, whatever you want to call it. Dr. Potter, thank you for joining me once again for this series, A Personalist Approach to Medical Ethics. And our episode today is about end-of-life care decisions. Thank you for joining us. So as we proceed, this is last but not least. This is really the nitty-gritty type issues we're dealing with today, the types of things we all need to account for. And I think it's very hard in our society. We don't want to deal with death. We don't want to deal with the ultimate question of the end of life, so to speak. And yet, as I said, your areas of expertise include geriatrics, palliative care, medical ethics related to many themes, but a real focus, concentration on end of life. And given the focus of the series, you approach these various subjects in your role as a medical ethicist and a personalist. Before we delve into the specific issues to address concerning end-of-life care decisions, what led you to dedicate so much of your own personal energies as a medical professional to palliative care? And if you could explain what palliative even means. Yeah. And if you could also, while you go into it, how does a personalist approach to medical ethics influence your engagement of palliative care and these other various issues related to end-of-life care matters?
Well, since this is a series on personalism and applying that in medical care, I'd like to just review for myself and for our watchers what I mean by a person. For me, a person is a construction of biopsychosocial relationships. And out of that matrix of relationships, and I use the word matrix carefully, matrix means the mother of relationships. The matrix of relationships emerges the spiritual dimension. And I would define the spiritual dimension as that unique, emergent, psychosocial function of making meaning, which for me is the crowning glory of the human person. The capacity to make meaning, to give value to things, to make things mean something to you, make sense of them. It's something that matters to you. That's the way that the spiritual dimension for me is creating for the individual that which will orient and direct and motivate their lives. Now that to me is a person. It's the what in medicine we call the holistic notion of a person. Of course, my Ph.D. dissertation was all around that, and I was contrasting a well-known academic psychiatrist who had done a pretty good job with the biopsychosocial model of the person, but he had nothing for the spiritual dimension. And when I put him up against Wolfhart Pannenberg, the great, now deceased, German theologian, who had a very strong sense of the spiritual dimension, it was apparent to me that medicine needed to adopt a philosophy of the person that included the spiritual dimension, as Wolfhart Pannenberg had so expertly and so theologically and so scientifically had done. And that's where I stand. Now, why was I engaged in that? Because all through my medical life from the beginning, I was searching for a way to understand the relationships between faith and medicine, always seeking for that. And finally understanding that if I would approach medicine as I was dealing with persons who are patients, I would do a better job of managing the whole of my professional life. I started out very early with the notion that the care of a person is best done by caring for a person.
Mhm.
And that approaching it all as a person is what I was engaged in. Now, persons die. Sometimes it's easy to get dead. Sometimes it's not. You know, sometimes it's a real burden, a real struggle, long and painful. But palliative care has come along more energetically in the last 50 years than before. The hospice movement, brought over to this country from the English woman Cicely Saunders, only was introduced in 1970s, early 1970s. And there were no palliative care fellowships until the 90s. Palliation comes from a Latin word, pall, P-A-L-L. A pall is a shroud. A pall is a shroud that covers the body in a funeral arrangement. Palliation is to cover the distress of dying, whether that's agitation, breathlessness, pain, nausea, the multiple ways in which the body suffers, the person suffers in the dying process will be covered over by appropriate medicines as well as appropriate relationships with people who care. And that's what palliation is about. It's easing the suffering of the dying process. So there you are. That'll be a easy to remember definition of palliation. The pall is the shroud that covers over the distress of dying.
Whether through medicine or the community of caregivers, actually both, right? I mean, it's both.
Absolutely. Medicine alone doesn't do it. It's got to be a combination.
Which again speaks to your point about the person, is that psychosomatic unity, the emergence, moving toward meaning making. It cannot be limited only to the natural scientific sphere. You're someone who brings to bear both the natural sciences and the social sciences in your work. And I think your whole approach to palliative care suggests just that. It's the medical aspect and the social aspect. Both are so vitally important.
Early on, I realized that in order to be a physician, you had to do double duty. You had to be a technological wizard and a compassionate guide. And you could be the technological wizard, and people would even say, oh, he's a good doctor, but they would say, but he didn't treat my mother all that well, or he didn't call us when my mom died, or whatever. To be a doctor is a double duty: technological wizard and comforting guide, compassionate guide.
And just on that point, as we proceed, even though we're not talking about palliative care with my son's situation, as he is in progressive care treatment, but very serious, very challenging situation with his traumatic brain injury, devastating traumatic brain injury. Right. We've seen some progress, some meaningful progress. Nonetheless, these are still heavy conversations, and I'm always looking for those medical experts that are doing double duty. And I don't like having to make up for, if I know of, even though I have no medical experience, so to speak, I've learned through this process, so I can pick up on where someone's done their homework or where they haven't as a professional. But I don't want to make up for the lack of empathy, and I don't want to have to make up for the lack of careful analysis either. And so I always marvel when I find someone who's doing double duty. It's so important to the patient family member. So,
well, I want to jump into this business about dealing with the person at the end of life. because there are times when the person themselves is fully capable of engaging in all the conversations necessary to be sure that that person's desires, that person's preferences, that person's wants, that person's values are honored in the dying process. On the other hand, we often in ethics have to make what we call a decision about decisional capacity. Does this person in fact have the capacity to make decisions for themselves? And that in itself is one of the ethical trials that we work through. I won't talk about that tonight because it's a pretty complicated process. It requires a lot of professional input and a lot of decisions that may not be altogether right. You know, it's easy to make a mistake in this area. So I just want to make the point that persons, the voice of the suffering person is the primary voice, period. As long as that primary voice still has the capacity to speak for the person.
Yes.
You know, once the capacity is lost, then what do you do? You turn to another network of persons, maybe a specific person that's been assigned by the dying person. Or if that's not there, if no one has been assigned by the dying person, then you have to make a decision. Who among the remaining people who care about this dying person ought to be making decisions around their dying process? Those are three levels of dealing with end of life that are constantly on my mind when I'm teaching and when I'm doing ethics consultations and when I was making decisions for my individual patients. No, is this person capable? Has this person assigned somebody else to decide for them? Or are we going to have to figure out who's got the moral authority to speak for them?
Yes, and that's always so challenging. And, you know, I know in my mom's situation, and she passed away right before COVID struck last year. She was 93. And I remember when the doctor came to us and said, okay, we're at that point where she could be passing soon. Do you want to do invasive measures like resuscitation? Well, he said, no, she didn't want that in her directives for some kind of intrusive action like CPR, because that would have broken her ribs. But it was still heavy. It was sobering. But we had to still make decisions based on what we thought her own intent would be. And I was the person responsible, but I did it in dialogue with my siblings. But it was still hard. It was still really hard.
Yeah.
And I appreciate how the doctor tried to work with us through that process.
Yeah, the conversations around dying are not easy, but they are so necessary. And once they are accomplished, they are such a blessing for the individual dying and the whole family. Now we have a sense of what mom would want.
Yes.
And it is a blessing, absolute blessing, that it's just immoral not to do it.
Not to prepare. Not to prepare. So, as you just said, Dr. Potter, reflecting on end-of-life care decisions is quite sobering and even disturbing to many people. So as a result, we tend to put them out of our mind until it's too late.
Yeah.
You just said we really need to address them. This is part of meaning making as persons. You know, how have you tried to help people see that such short-sightedness has long-term, sometimes devastating implications?
Yeah. Well, you know, every time I enter into a set of relationship where there has been a death, let's say a death, maybe it was a good death, what we'd call a good death, you know, everything was prepared, people were expecting it, and the palliative care was effective, and everybody was gathered around, you know, this is pre-COVID days kind of thing. You know, even in that circumstance, I would be finding that opportunity to speak to every one of those people engaged Have you had what we called at Midwest Bioethics Center in Kansas City, where I was working primarily for the last 10 or 15 years? Have you had that caring conversation? That's what we ended up calling them, Paul, the caring conversation. Have you had that caring conversation in which you have either told your children what you want, or you, child, have asked your mother or father what they would want? You know, have you had the caring conversation? So just keeping it in mind so that they begin to think about it. Oh my goodness, it went so well. What if mom had not given this information to us? Maybe we ought to be proactive in doing that for our kids, or ask our folks about this. And I just think to keep the conversation going when there has been a death, or when a death is anticipated. You know, that's the other place where there's been a death or a death is anticipated. You know, everybody engaged needs to be asked the question, have you had that caring conversation that will help everybody around you know what would be your preferences in the time of your dying? Mm-hmm. Yeah, and obviously the best you can anticipate. Clearly there are things that you can anticipate and things that you cannot anticipate. On the other hand, there are a lot of ways in which you can develop an advance directive in a way that will give guidance to your family and to the professionals caring for you as to just what it was on your mind when you made out that advance directive. An advance directive, by the way, is really quite a remarkable thing. In Kansas, where I practiced and taught most of my life, we had what we called a living will very early, 1970. Can you imagine? I mean, that's way back. That's ancient history. And we were one of the first states to have that. And it was a fairly effective instrument, but it was only probably about 5 or 10% of the population had one. Well, in the late 80s, there was a tragic accident on the highways of the state of Missouri. And a young woman by the name of Nancy Cruzan lost control of her car on a slippery highway, was thrown unconscious into a ditch full of water, where she was partially submerged, unconscious. Was found, brought to the hospital, treated successfully with resuscitation, and ended up in what was known at that time as the persistent vegetative state. Being fed by a feeding tube, she recovered to the place where she could breathe on room air without assistance of a respirator. But after a year or so, her parents had asked that the hospital stop the feeding and allow the daughter to die. Because it was clear to them, they had made the decision that the prospects were such that the likelihood of recovery was so minimal that from their point of view, they thought the right thing they would want to do for their daughter was to allow her to die. Well, the hospital and the state of Missouri objected. And all this went into a lawsuit, went to the Supreme Court in 1990. And the Supreme Court said, yes, the state of Missouri is allowed to decide whether somebody is going to be kept alive or not. However, the Supreme Court said, the patient's rights ought to be recognized. Immediately, the state senator from the state of Missouri went to Congress, National Congress, remember that he was senator in the National Congress, introduced a bill which was called the Patient Self-Determination Act. And it was passed in that year and became law in December of 1991. And it said that every state in the union will have a law that allows a person to develop an advance directive that tells the professionals and the hospital or whatever healthcare facility they're in what their desires are and they must be followed. So there it was, 1991, that came to be the law of the land. About the same time, there was an organization begun in Kansas City called the Midwest Bioethics Center, dealing with healthcare issues from an ethics point of view. And we had been, in fact, with the senator, helping him to develop this act, and sat with him in Congress when he introduced it in 1990. We became a center, one of 3 national centers dealing with end-of-life issues. In 1995, then, in response to a very, very damaging article in a medical journal that demonstrated that even in the highest of medical facilities, we were doing a very bad job of caring for dying people. We were not managing their pain. We were not meeting their needs. We were not obeying their preferences. We were not following their rights. It was clear that something had to be done. The Robert Wood Johnson Foundation put out multiple millions of dollars. And our organization in Kansas City was one of the 3 stretched across the United States, one on the East Coast, one on the Midlands, one on the West Coast, that were engaged for 5 years in a strong effort to improve care at the end of life. And one of the primary activities we had was developing caring conversations, encouraging the people to do so. And it was a national effort that I was engaged in, traveling all over the country, pushing the idea, the simple idea that we ought to talk about what are the preferences of people in their dying process. At the end of that effort, there were about 50, we measured there were about 15% of the American population had an advance directive. That has changed very little over the last 15 years. Maybe it's gone up a little bit, but not much. Yeah. About 15 to 20% of people have an advance directive. I did a study in Kansas City. Of those who said they had an advance directive, how many of them brought them to the hospital? 50%. 50% had it on the chart where it could be seen and followed by the professionals. There's a lot to do. There's a constant effort to improve care at the end of life. But one of the things that you as a patient, or you as the relative of a patient, or you as a substitute decision maker for a patient, is to be sure that whatever you've got in terms of advance directives, even handmade notes from a patient, are on the chart and everybody knows they are there and what they mean. That is, that will help boost along care at the end of life. Now here in Oregon, we've been pretty advanced about this. At OHSU, for instance, there's been a very fine ethics organization up there that's integrated into the medical school, completely integrated. When I came out here 17 years ago, I began to work with them on a volunteer basis primarily, although I was hired for a little while, but that's another matter. But you know, they are top notch. They're leaders in the country. And they produced another kind of a document. In addition to the advance directives, they developed what's called Physician's Order for Life-Sustaining Treatment. And it's a sheet of paper that can be signed either by a practicing physician, or now we have it to where the physician's assistant or the nurse practitioner in that office can sign this. It can be put up on the refrigerator door in your home. And if the ambulance is called and it's through some crisis that you're in, they will look at that, what's called a POLST form, P-O-L-S-T, Physician's Order for Limiting Life Treatment, and they will follow that. It is so remarkable how much it helps guide the appropriate care of somebody who's dying, so that everybody engaged knows what that person wants done. It's the way to be a personalist ethicist, is to see to it that the person gets to guide what's done to them. that's my little preaching for the moment, Paul. You have questions, no doubt, but that's my little preachy part right there.
Well, and I think as a personalist, you want to make sure that the person who's most vested in the process, namely the person whose life is at stake, is making the decisions before them as much as they possibly can. That's a personalist approach. It's not that the state makes the decisions for them. It's not that the market makes the decisions for them. It's that they make the decisions for themselves. And if people really want to take seriously their own personal agency, and in America, you think we would, then we should develop these documents and make clear what our own prerogatives and desires are, because otherwise others are going to make those decisions for you. And it can be very stressful. It can be very stressful for many parties in trying to negotiate decisions on these matters. And it's in everyone's best interest that we take matters, shall we say, into our own hands. So I appreciate.
And I'd like to add to that too, Paul, that in the making out of an advance directive, what you can do is assign someone to be your substitute decision maker, sort of a power of attorney is what it's called technically, but we like to call it a substitute decision maker. You can assign your wife, your husband, your sister, your best friend down the block. So somebody can be assigned to be your substitute decision maker when you lose that decisional capacity. If you do, you see. And that I find that very, very important, because so often in the process of dying, a person is going to be either losing capacity because of the illness, or their mind is clouded by all the medications that we're using to try to keep them comfortable. Both of those things intrude upon the decisional capacity. So assigning that person to be your substitute decision maker is really a critical piece of your advanced planning.
And that's what we did with my mom's situation. I had oversight. If she wasn't at a position where she could make that determination, and she wasn't conscious. And so we had to work on what she had already provided in trying to honor her own intentions. So, but we had that. Fortunately, we had that. And my siblings and I were able to work from that in support of her. Reflecting on end-of-life care decisions, as I said, is quite sobering. It's interesting that in a prior episode, your determination to break the news to a patient that he was dying helped him to live the last weeks or months of his life to the full together with his spouse. So preparing for the end need not be morbid, but rather life-giving. I think that's your desire. You want to see it being life-giving, not an instance of morbidity. How can this be? It appears so paradoxical to many people in our society. I think that's why we don't make these decisions.
Yeah.
We want to go to Disneyland instead.
I was working with this idea years and years and years ago, and I wrote some things down that I went back and gathered up for our conversation here. I called this in this particular outline, listening with the third ear. What I meant there, listening with the spirit. But so you're asking the meaning questions. Here I'm talking to somebody, they know they're dying and I know they're dying. I ask the meaning questions. Do you have a sense of purpose in life? Do you feel good, or you feel unsettled about the future? Do you understand yourself? Do you have a sense of well-being even though you're dying? What worries you? What are you afraid of? What do you hope for? Those are legitimate questions that I think any of us, whether we're in an authoritative position as a physician, or as a friend, or as a pastor, perhaps, you're not going to sit down and say, well, I've got 9 questions to ask you. No, it's not that. But to sit down and ask, is there anything you need to get done in the time you have left? Anything you need to think about, repent for, confess to, whatever. Whatever it is, what is it that you need to do in this final time? I'll be here to help. And I've often I've often used this following thing. One of the leaders of the country that worked with us, he was from Montana, which was the location of the third, the far west cluster that's working with the Robert Wood Johnson Foundation. He came up with, he called the completions. Get these. This is what the dying person needs to say. I forgive you. Forgive me. Thank you. I love you. Goodbye. I forgive you. Forgive me. Thank you. I love you. Goodbye. And you know, you can elaborate on each of those, but that's the way to complete a relationship. Pretty strong stuff. From a professional point of view, what I would teach all the students that I had in medicine and nursing, I said there are 5 promises. Now, I wrote them down for us. I promise that I'll tell you when I think you're dying. You know, we did a study, and I've done a study within the last 10 years. And even though more physicians are being willing to tell people they're dying, it's still tough. And I don't expect more than half of physicians to really be willing and able to skillfully tell somebody they're dying until it's so obvious everybody knows. But I promise that I'll tell you when I think you're dying. I promise to respectfully listen to your concerns. I promise to help you plan for your care, advanced directives. I will do my best to keep you comfortable. And I will talk with you about hospice or palliative care. I think that professionals owe that to patients. Willingness to tell them when you think you're dying, to listen to their concerns, to plan for their care, to keep them comfortable, and talk with them about the value of hospice and palliative care. I just am so strong about that, Paul, that I think it ought to be expected by every one of us dealing with healthcare professionals. Expect that they'll keep those 5 promises.
Yeah, those are beautiful. In addition to those statements that your colleague put forth, those last ones that you just listed, were those ones that you developed yourself?
Yeah, I developed the 5 promises. Yeah, just out of my own practice. You know, I felt like that was what made me able to relate to the dying patient as a person. That I'd tell them what I think I know, that I'll listen to their concerns, and that I'll help them plan for their care. And I'll do what I can to keep them comfortable with all kinds of palliative work. And I won't necessarily do it myself. I'll get that hospice team in here to help make your dying process as comfortable and compassionate as possible. I like beautiful. The word comfortable. You know, most people think of comfortable as being soft. It derives from the Latin com fort. The prefix com means with. The root in the middle, fort, means strength. To be comfortable is to have that strength to die. And that's what we owe to people who are entering the dying process. Give them the comfort, the strength to die well.
Dr. Potter, I sense how you are drawing together a lot of the threads of the previous interviews. We've done 7 besides today.
Yeah.
And, you know, we talked about what is a person at the outset. We're dealing with that today. What is a person? We dealt with the 3 cardinal questions. What's going on here? what ought I to care about and what is the fitting response? You're addressing that here now. You're also addressing objectivity and empathy. I mean, I know you well. You've been in conversations with us on a variety of very sobering matters in support of my son and his progressive care situation from his traumatic brain injury. And you bring the objectivity, the analysis, looking at MRIs and such with other professionals, but also that empathy, what you're accounting for here. And we could go on. And I think all of this is part of what's important for us as humans. You know, a lot of people watching this series, you know, over the weeks, months, and years ahead, they're not going to be medical experts, many of them. Some will be. But I still think there's something here for everyone to take away from, besides advanced directives and things of that sort. This is what is important for us as humans, to account for being truthful. You know, I'll tell you when I think you're dying, and I'm going to be there for you. It's that comfort to provide that support for you to be strong in the midst of making those ultimate decisions and passing into the next stage of life, passing away and moving forward, so to speak. But it's about human dignity. It's about human flourishing. It's about honoring one another. So there are values here and principles that extend to all of life, from objectivity and empathy and beyond. What would be some of the recommendations you would make to viewers to get their house in order, to get our house in order? Here I'm thinking of advanced directives, which you've already alluded to. What is an advanced directive? You've already kind of gotten at that a bit. When should our viewers and listeners write up theirs? Where should they place them? You mentioned refrigerators. Are there other documents you would recommend viewers and listeners to make? And you've already alluded to some of that too. What would you want to say to viewers here today over the next month or two? Make sure you've done this.
Well, I guess I would just sort of ask them to do what I've done. I went up to OHSU, of course, because I can easily get it, but I got the 3-page form that the state of Oregon has produced for advanced directives. You don't have to use that in order to be valid, but it's a good guide. So find out how to get that. Go to your doc, go to a medical office or someplace, find out, get a form. Fill out the form thoughtfully, because there are questions there that you need to think about. Now, what if I am in certain kinds of situations? Answer it honestly, clearly, completely. Answer it in conversation with those people who are engaged in your decision-making process, whether it's a spouse, children, brothers and sisters, whoever, close friends, pastor, whoever. Do it not by yourself. Do it in consultation. It'll do two things. One, it'll help you clarify your own thinking as you bounce it off with others. And secondly, others will more fully understand what it is you're trying to communicate there in writing. So do it with others. You make 2 or 3 copies and you pass it around the family, but you take one of them to your doctor. Now, the problem with taking it to the doctor is that in this day and age, often your doctor is not the doctor that'll be seeing you in the hospital if you should end up in a hospital. The hospitalist is going to be seeing you. So you need to have one right behind your computer on your desk in a little inside an envelope with a big red mark on one edge, so you recognize it easily. And you just tell everybody, now, if you call the ambulance on me Friday night, you be sure that you stick this envelope in their hands and say, take it to the hospital. So have it available, have it right there where you know where it is. It's right behind my computer here, okay? And everybody in the family knows that. There's one behind my computer, there's one behind my wife's computer. And our 2 sons and her sister know exactly where they are and what's supposed to be done with. Somebody is going to follow me to the hospital, and they're going to carry my advance directive and see to it that it gets put on the chart. That to me is assurance that you have done what you can to be sure that who you are as a person will be treated with the dignity you deserve in the healthcare setting. That's the way it is. Now, I want to reflect before we finish here, Paul, on one other item, and that is this. You know, I'm into this because I practice medicine. But I practiced medicine in a way that I wanted to understand at the end of my practice days that what I have done is to follow Jesus. To follow Jesus in the care of persons who came desperate to him in illness and in captivity and in oppression of one kind or another, and bad situations and whatever. And I feel like what I have done in caring for myself has been to shift that around and try to care for others. And I think every one of us who's listening to this program ought to be eager to participate and initiate and participate in a caring conversation. Have you prepared your advance directive? That's the message that I want heard. It's not all that complicated, folks. It requires some attention, some thought, but it is a blessing to have done the caring conversation and put your advance directive where it will work for you.
And in so doing, you're also working for your community, your family, your loved ones, even the medical community, because it helps them. It helps everyone. And we're all in this together. Somehow or another, we're all in this together. And what final recommendations do you make to help patients, future patients, and their loved ones prepare for the end that waits us all? I mean, is this, for a lot of young people, they'd say, I don't have to worry about it now. It's not going to happen. But you just mentioned a story about how it wasn't the parents, it was the young lady, the tragic incident where the parents determined after a year to, in a sense,
she was 26 years old. She was
26 years of age, 26. What final recommendations would you make?
Well, I've done all my preaching. So, this sounds simplistic, but I honestly believe it. Pay attention. Pay attention to the opportunities to help anyone you know and love to engage in the kind of life that is always prepared for death. That to me is one of the marks of a faithful person. To have faith in God so that as I live, I am prepared to die. And that for me, it means you've got to pay attention. To what? Well, to what's going on around you, to what really means, what really you ought to be caring about it, and what you're doing about it. Paying attention to life is what you have to do in order to prepare for dying. Amen.
Amen. And it reminds me of the words of the Apostle Paul, for to me to live is Christ and to die is gain, as he wrote that from a prison cell in Rome. And I appreciate very much the sober reflections, the life-giving reflections on a personalist approach to medical ethics over these 8 weeks of dialogue. And I just want to thank you for your passionate commitment to Jesus Christ and your passionate commitment to patients. And Dr. Potter, thank you very much. Thank you to those who watch and will be watching these reflections, this series of reflections on a personalist approach to medical ethics. For Dr. Robert Potter and myself, Paulus Metzger, thank you for joining us. Blessings to you on your life's journey. Goodbye.